Welcome to ESP and the Baptist Health System. This orientation is designed to bring new physicians up to speed on important policies and processes within the Baptist Health System. Although it's designed to be as thorough as possible, if there are things that you still have questions about, please do not hesitate to contact me, Byron Freemeyer, or any of the emergency department medical directors. The first must-know process that we'll talk about is sepsis. All patients that have a potential source of infection should be screened for severe sepsis and septic shock as soon as an infection is identified. The nurses are supposed to initiate the sepsis screen, but if they do not, we should initiate it or ask them to. If the patient has a potential infection in 2 Sears criteria, we should order the CBC, CMP, UA, point-of-care lactate blood cultures and urine cultures. The nurses also are able to do this by standing delegated order. For a positive screen for either severe sepsis or septic shock, we should complete the 3-hour and 6-hour bundles for severe sepsis prior to the patient leaving the emergency department. If the patient screens positive for severe sepsis or septic shock, we should call a sepsis alert. This notifies the EICU, the electronic ICU nurse, who will follow the metrics and help us make sure that we're completing all important steps. Here's the Baptist Health System severe sepsis screening tool. It has a source of infection in 1, Sears criterion 2, evidence for organ dysfunction in 3, and in the center with the bold outline are the criteria for septic shock. The nurses are empowered to start this and should start this on any patient with a presumed source of infection. So, all patients with severe sepsis or septic shock need to have the 3 and 6-hour bundles completed. The 3-hour bundle includes the point-of-care lactate, blood cultures obtained before antibiotics, antibiotics administered, fluid resuscitation for septic shock, the 30 cc's per kilogram crystalloid infusion. This is abstracted only for lactates greater than 4 or the mean arterial pressure less than 65, but we suggest considering this for all septic patients. The 6-hour bundle for severe sepsis and septic shock includes a placement of a central line for patients that are persistently hypotensive after their 30 cc per kilo bolus. If the patient has continued hypotension after fluid resuscitation, they should have pressors initiated. And if the patient had a lactate that was greater than 2 initially in the 3-hour bundle, this should be repeated after the fluid bolus in the 6-hour bundle. And when ordering the lactate, we should order the point-of-care lactate or the POC lactate. This is done at the bedside. If we order standard lactate, this is drawn, placed on ice, and sent to the lab. Here's some key items to consider when treating patients with possible sepsis. The time for the 3 and the 6-hour bundle starts at the patient's arrival to the hospital, not when we identify the patient as being septic. We should screen patients as soon as we identify a possible infectious source. Ordering antibiotics empirically prior to lab and x-ray will help assure that the patient receives their antibiotic in a timely fashion. For example, if the patient has a fever and you believe they have an intra-abdominal infection, you should order antibiotics to cover the presumed source of infection prior to obtaining a definitive diagnosis. Remember, blood cultures must be done prior to antibiotics. If we are close to the time that the 180 minutes for the IV antibiotics, we should verbally tell the nurse that we are close to that time so they can prioritize getting the antibiotic in. You should use the sepsis order sets whenever possible because they are embedded with all the goals for the septic patient. You need to document that all of the 3 and 6 hour bundle items are documented on your T-sheet as being completed. The metric is an all or none, so every fallout is very important, including the repeat point of care lactate in the 6 hour period. Remember, the 3 and 6 hour bundles must be completed before the patient leaves the emergency department. We should not defer to other care providers for central line placement or completion of the point of care, the second point of care lactate, or the initiation of pressors, which requires the placement of a central line. Here is a copy of the severe sepsis algorithm. This flow diagram should be available in each of the EDs and is also available on the Baptist intranet under physician orders. This shows what the 3 and 6 hour bundles contain so that we can review these at the time of patient care to make sure we're completing them. On a related topic, patients with suspected central line infections should not have blood cultures drawn from the central line to diagnose infection. The diagnosis is done through positive cultures from the periphery in the absence of another source. Cultures from the central line have a high rate of false positives. We should also not remove the central line for suspected central line infection unless there's gross contamination at the site. We should encourage our colleagues not to have the central line removed and the catheter tip sent for infection. Again, this is not the way central line infections are diagnosed. They're diagnosed through peripheral blood draws, positive for an organism, and the absence of another source of infection. Blood cultures, when they are obtained, should be obtained from fresh venous sticks. If you have to place a central line because of persistent hypotension, you can use the central line to obtain the blood cultures. You can also draw the blood from a newly inserted IV. At least 2 blood cultures should be obtained. There is no timing requirement for how long between the 2 cultures, so they can be done at the same time as long as they are from 2 different sites. All 5 of the Baptist Health System hospitals are certified stroke centers by the American Heart Association. Furthermore, St. Luke's is a comprehensive stroke center. As part of this stroke center, we continuously monitor and try to improve metrics related to stroke care of our patients. One key goal is that greater than 95% of our patients who meet the eligibility requirements for TPA or alteplase should be given TPA within the first 60 minutes or have an acceptable reason noted why they were not given. Please note that a delay by a teleneurologist is not an acceptable reason. So in instances where the inclusion-exclusion criteria clearly show that the patient is a TPA candidate, there is no reason to wait for the stroke teleneurologist. We can order these in the ED using our stroke order sets. When you document the reasons why the patient did not meet the criteria for uh, TPA, the T-sheets have acceptable reasons. You can also just document that the patient had an NIH stroke scale of 0. This will alert the abstractors that the patient did not meet the criteria for TPA. When we do give TPA, we need to make sure that we use the stroke inclusion exclusion order sets for all patients and use the stroke order set to administer TPA. No free hand or free text TPA orders will be accepted. This is a requirement set forward by the Hospital Medical Executive Committee that all stroke patients will have the stroke order sets used. You can do this either in the computer order entry or in the pre-printed stroke packets. In addition, all patients that have a possible diagnosis of stroke should have a dysphagia screen completed prior to any PO intake. The CPOE, or computer physician order entry, now has a dysphagia screen attached to all CT head orders to assist us in completing this. Remember, patients that we admit with TIA, intracerebral hemorrhage, subarachnoid hemorrhage, all need documentation of the reason why TPA not given and a dysphagia screen prior to PO. I know this sounds counterintuitive and silly, but it is a metric that we're held to. The most common fallouts are for the TIA when their symptoms have completely resolved. Again, you can write NIH stroke scale of 0, or simply write that the patients did not receive TPA because their symptoms had resolved completely. Again, the reason has to be tied to not giving TPA. So what are some of the acceptable reasons for a delay in giving alteplase within 60 minutes of the patient's arrival? Some of the reasons can be social or religious. For example, I can't make a decision until I talk with my priest or my brother. The patient may have also initially refused and then changed their mind and decided that they did want TPA. Medical reasons may be that the patient has hypertension that we're having difficulty controlling, so that the patient would be a candidate for TPA. Again, we have to tie the reason to not giving within the 60 minutes. For example, you could write the patient required multiple medications to lower blood pressure, and this delayed giving the TPA in the 60-minute time period. Sometimes it may be difficult to sort out whether the patient actually is having a stroke. So if there's a seizure at onset or the patient had initial hypoglycemia, this could be an acceptable reason that you could document for a delay in giving the TPA within the 60-minute time period. If the patient requires intubation or CPR, these also are reasons that the patient could have it documented that they did not receive it within the 60-minute time period. These reasons are also on the order sets for stroke, so that if we're giving TPA and it is over 60 minutes, we can easily document what the reason was. So there are a couple of ways you can document the delay in the TPA beyond the 60-minute time period. In CPOE, there's an order for TPA, and right after that, there's a box that shows the acceptable reasons. The eligibility reasons can be social, religious, or initial refusal. Please note that care team unable to determine eligibility is no longer an acceptable reason. Medical reasons which are acceptable for delay in TPA beyond the 60 minutes from arrival would include hypertension requiring aggressive management, such as nicardipine or labetalol drip. Further diagnostic evaluation to confirm stroke, for example, if the patient is initially hypoglycemic and remains paraplegic even after receiving D50, this may be a reason. CPR in itself is a reason that TPA can be delayed. Investigational or experimental protocol, we are not currently involved in any experimental protocols for TPA. Please note the most important aspect here is there is no acceptable reason in TPA delay because of not being able to talk to a neurologist. So delay by teleneurology is not an acceptable reason for delay beyond the 60-minute time frame. And we should not wait for the teleneurologist to tell us that the patient is a candidate. So the question may come up then, why do we have teleneurology? Well, teleneurology is there to help us in difficult circumstances where we cannot determine whether the patient is or is not a stroke, or whether they can meet criteria. For the straightforward cases, we can use our own inclusion-exclusion criteria and administer TPA to the patient. The T-sheets also have an area on the stroke or the neurosymptoms deficit T-sheet where we can document delays in TPA administration beyond the 60-minute from arrival window. Now for the NIH stroke scale, all acute stroke patients have to have an NIH stroke scale done by the physician within 15 minutes of arrival. Our definition of acute stroke is within last known well of 6 hours. If the patient is beyond this but still is admitted for a stroke or TIA, they need an NIH stroke scale done, but not within the first 15 minutes. These NIH stroke scales are done by the nursing staff prior to admission to the hospital. Please remember that when you do the NIH stroke scale or document the completion of it, we have to date and time it. Otherwise, the abstractors won't know when we completed the NIH stroke scale. So here's some more information about strokes. We should use last known well with a date and time for the patient, and avoid using onset. Again, we need to document the reason a TPA is not given on every stroke and TIA patient, regardless of when the last known well is. We need to do dysphagia screens on all patients who might ultimately have a diagnosis of stroke, including hemorrhagic strokes. Don't wait for the teleneurologist in patients that clearly meet the criteria for TPA. We need to document the reason TPA is not given within 60 minutes. And there are no freehand TPA orders. All TPA orders have to be completed with a stroke order set with completion of the inclusion-exclusion criteria. An exciting new treatment that is available in the Baptist Health System is intra-arterial therapy done at our Comprehensive Stroke Center at St. Luke's. The algorithm that we have adopted in collaboration with the interventionalists there at St. Luke's is noted on this slide. So for all patients that have a stroke onset less than 6 hours, we should consider them for IV Activase and intra-arterial therapy, and then document this consideration. If the patient meets the criteria for TPA or Activase in the 3 or 4.5 hour time period, we should give the IV Activase. In addition, if the patient has an NIH stroke scale that is greater than or equal to 10, in both TPA patients and non-TPA patients, we should at the same time order a CTA head and neck and a CT perfusion while contacting the interventionalists at St. Luke's Baptist via Access Baptist to discuss the patient's care. At the same time, we should also have Access Baptist, the transfer center, contact Acadian for transportation of the patient. If they do not have an NIH stroke scale of 10 or greater, they should be admitted at the local hospital. The next few slides show a more detailed version of the previous algorithm, showing who does what at what time. The important thing for the emergency physician to know is if the patient has an NIH stroke scale of 10 or greater and symptom onset less than 6, that they should call a neurointerventional alert through Access Baptist. We should also simultaneously order the CTA head and neck as well as CTP. Of note, we should not wait for the creatinine to return if the patient has an NIH stroke scale of 10 or greater and symptom onset less than 6 hours. In documenting our consideration for intra-arterial therapy, we have added the reasons onto the T-sheets for easy documentation. For patients to be a candidate for intra-arterial therapy, they have to have a time from last known well to groin puncture by the interventionalist less than 6 hours. So if the patient arrives in a time where it's too late to get the patient, say, from Mission Trail Baptist to St. Luke's in the 6-hour window, this could be noted as a reason. Or if the deficits are too mild, say the patient has an NIH stroke scale of less than 10, refusal by the patient or a patient's surrogate is another reason. After we've discussed with the interventionalist may also decide that the patient is not an intra-arterial candidate for a variety of reasons. One of the primary ones is lack of a major vessel occlusion. But again, we will document this after discussion with the interventionalist. Changing gears to another metric, for the MI core measure metric, every patient that we admit with possible ACS should have aspirin given in the ED. We can also document that the patient was given aspirin in the ambulance or took it at home prior to arrival. We should document the time that we call a heart alert for STEMI patients and when the interventionalist was paged. All the hospitals except for Mission Trail Baptist have interventional cath lab capability. At Mission Trail Baptist, a heart alert activates the Baptist Medical Center downtown cath lab. At Mission Trail, if we have a STEMI, we should contact the interventionalist on call at BMC, not the local cardiologist at Mission Trail Baptist. We also should send the patient without waiting for the cardiologist to call back. Central line associated bloodstream infections, or CLABSIs, are very serious infections that have a high mortality rate in patients. They are also a publicly reported metric. To prevent these serious and devastating infections, the hospital system has developed a bundle for the insertion and care and diagnosis of central line associated bloodstream infections. Our part in the central line associated bloodstream infection is to make sure that we follow the insertion central line bundle. The nurses will observe and document whether we do or do not comply with the central line bundle. What is the central line bundle for us? Hand hygiene, including washing hands, no jewelry. We need to use a full barrier precautions with a large drape covering the patient's face and a large part of their torso. We should be gowned and gloved with a mask, hair protection. We should use the subclavian or the internal jugular as the preferred sites. In our system, the subclavian has the lowest infection rate when compared to internal jugular. If the femoral is used, we must document a reason. For example, patient has scarring preventing subclavian and internal jugular placement. We should also use chlorhexidine prep prior to placement of the central line. The only exception to the central line bundle would be in a truly emergent situation, such as CPR in progress. In this case, the full hand hygiene, gowning, draping, full barrier protection do not have to be followed, but the central line that's placed should be changed out as soon as possible when the patient is stabilized. Foley catheter-associated urinary tract infections are another important infection for our patients and another publicly reported metric. All catheter-associated urinary tract infections will be reviewed by quality for appropriateness of need for insertion and care after insertion. Appropriate reasons for insertion would be such as in a critically ill patient, to monitor carefully the urinary output. A patient has a urinary retention or bladder outlet obstruction. If the patient has prolonged immobilization, if the patient has open sacral or perineal wounds and are incontinent, or if the patient is a hospice patient to improve comfort for the end of life care. Inappropriate reasons for Foley placement would be dementia or confusion, or for urine specimen collection. We can do an in and out catheterization, but not placement of a Foley solely for urinary collection. Incontinence in itself if the patient is not immobilized, morbid obesity, healthcare worker convenience, or even if the patient requests it. Specifically, Lasix is not an indication for Foley catheter placement in itself. So here's our ED Foley placement algorithm. So a patient presents to the ED. If they have a Foley in place, the patient should be reviewed by the nursing staff to see if they have an ongoing reason to have the urinary catheter. The hospital has a standing delegated protocol where the nurses can remove the Foley if they do not meet the criteria. If the patient comes without a Foley, there has to be a physician order for a Foley prior to placement. The nurse should not come to you and say, I put a Foley in, can you put an order in for me? So the first step, no Foley without a physician order. So if the physician orders it, they still have to have an indication present. If there is no indication present, then the nurse should notify the physician that there's no indication and that they can't, by hospital policy, insert the Foley. If there is an indication and an order, then the Foley can be placed. Let's talk about the admission process for a minute. This is essential that we do this correctly. This is the most common complaint that we've had from private physicians, that we gave their patient to the wrong person. With insurances continually changing and hospitalist groups continually changing, it's essential that we do this correctly. The good news is that this has been drastically simplified for us in our system. All we need to do is determine that the patient needs to be admitted and write an order, place call to admitting. Then the burden of checking on the preferences of the primary physician, what the insurance status is, who admits that insurance and that physician's preferences are all left up to the unit secretary. The unit secretary calls the appropriate physician, freeing the emergency physician to take care of patients. Once we've spoken with the admitting physician, we should request to use the bridge orders in our discussion with the admitting physician. These bridge orders, which we complete, take about an hour off the length of stay in the emergency department and are the only admitting orders that the emergency physician will write. They can be used for all non-ICU patients. The emergency physician should discuss with the admitting physician the status of the patient. That is, will they be inpatient or OBS, where they're going to go, such as the floor, ICU, any additional orders that need to be placed on the patient's chart, such as stroke orders or sepsis orders. Then we need to document the physician that we spoke with their physician number. Here's a copy of the bridge orders. There is no electronic version currently available, so we'll have to do this by hand. In completing the bridge order, it is important that we understand the consequences of inpatient versus observation. This puts the hospital at risk for millions of dollars, specifically for Medicare patients that are admitted as an inpatient and then discharged within 24 hours. Generally, patients that have a specific diagnosis, such as an MI or pneumonia or appendicitis, should be admitted. Patients that have a symptom base, such as chest pain, abdominal pain, shortness of breath, should probably be admitted as an observation patient. When we're completing the bridge orders, it's important that we discuss this with the admitting physician. Okay, so we talked earlier about the process for admitting patients, that the emergency physician makes a decision to admit the patient, then simply writes the order, call admitting. But what about patients that have a primarily surgical problem, such as appendicitis or a fractured hip? In general, it's best still to place the order for admitting, because surgeons in general will not admit patients primarily. Then you can obtain the preference of whoever will be the admitting physician to call. In practicality, most of the time, even with managed care, they'll want us to get the surgeon on call. For patients without primary care physicians or who do not have a surgical specialist that they already have a relationship with, we need to use the call roster for these patients. For example, if a patient has no primary and no previous orthopedic history and they have a hip fracture, we need to use the on-call roster for the orthopedist. Another circumstance is where the patient has a surgical problem, but we do not have the surgical specialty on the call roster. In this instance, we can't admit to the hospitalist without securing surgical consultation. We'll discuss this later, but we have a new resource in the Baptist Health System in that we have a transfer center that will help us secure needed specialists if they are not available on the call roster. Next, we see the form that we use in the emergency department to follow up on discrepancies or lab that's returned after the patient's been discharged. This is primarily done with cultures and discrepancies in x-ray readings, either between the emergency physician and the radiologist, or sometimes there's a reread by the radiologist and they will contact us with the discrepancy. The labs that we typically follow up on are cultures. Occasionally there'll be GC and chlamydia DNA probes that we follow up on. Please note also that all strep screens are followed up with a culture if they are negative initially. It requires someone to look at this and make a decision about what to do. We can either have the patient return to the ED or decide that the care is appropriate and the patient doesn't need to know. We can tell the patient what the findings are and have them follow up. If we cannot contact the patient, we can have the charge nurse send a registered letter. In any event, this is completed and becomes a part of the permanent medical record. At hospitals where there's a mid-level working, if they are available, they can complete these as well and come to us for any questions they have. Because of this need to follow up and because many of these tests do not change our therapy for the patient, we ask you to limit cultures, DNA probes, flu, RSV screens, and throat cultures, or strep screens. The GC and chlamydia probes are done at one hospital, North Central Baptist, and it takes 2 hours once the specimen is received at the hospital. We ask that you either treat the patient or wait till the results are back. For throat cultures, we also ask you to use the Centaur criteria to make a determination about whether to treat or not to treat. Flu and RSV screens, unless the patient's going to be admitted, do not change the therapy for the patients. And also the rapid flu screen has a very low sensitivity compared to physician clinical judgment during a time of a flu outbreak. If we read a x-ray prior to the radiologist reading it, we need to make sure that we document the reading in PACS. This way the radiologist can know what we thought and agree or disagree. We do not do preliminary readings on CT or formal ultrasounds. Furthermore, the radiologists are available 24 hours a day, 7 days a week to read films. Although at St. Luke's Baptist they use a different system, still they're available to read films 24 hours a day. For psychiatric admissions, the current process is for us to medically screen and clear the patient for admission and then contact the Baptist Assessment Team, or the BAT team, Behavioral Assessment Team, to evaluate the patient for placement. There are no set required studies that need to be done prior to clearing the patient medically. However, many of the psychiatric hospitals and psychiatrists will not accept patients without an alcohol level, urine drug screen, CBC, CMP, pregnancy test, and aspirin and Tylenol level if there's any indication that they may have taken an overdose. Once you've contacted the behavioral assessment team or the BAT team, this is the algorithm they'll use to decide on placement. The key is that unfunded patients have beds that are designated by the state at private hospitals where they pay for it. Unfortunately, if the patient is unfunded, they will need not only the BAT team to assess them, they may need the MCOT team to assess them also to see if they're appropriate for their bed and if there are any beds available. Once again, though, this process is not something that you'll need to follow up, that the BAT team will initiate this. However, if there's prolonged ED stays because the patient's waiting for assessment, we need to make sure that we reassess the patient periodically during their stay and at any shift changes and document this handoff. Here are the dictation instructions for the hospital. The use of this was primarily for documenting unusual circumstances that would be too difficult to handwrite out. I also use this for completion of missing T-sheets. I will document an addendum with the information that should be there from the T-sheet. The easiest way to think about dictation for me is just to call the operator and ask for dictation and follow the prompts and remember that the ED code is 60. We have standing delegated nursing protocol orders for when the physician is not immediately available to see the patient. The nurses should select the appropriate protocol from the CPOE list. These greatly expedite patient care, especially if there's any delay in the physician being able to see the patients. We do have to co-sign these as a CMS requirement. So when you're trying to close out your chart, it may bring you back to the orders page. It's because you need to co-sign the nurse's protocol orders. We have many competing goals in the emergency department. A really important goal is patient satisfaction. I think that physician satisfaction is largely determined also by patient satisfaction. It's just more fun taking care of patients that are happy. So this tool, AIDIT, will help us accomplish that. So if you aren't familiar with it, what you do is you acknowledge the patient. Just like you'd walk up to anybody, you would say, "Hello, I'm Dr. Freemeyer, and you're Mr. Smith." And then after you've acknowledged the patient and introduced them and discuss with them their medical problem, given them an idea about what's going to happen and how long it's going to take, say, well, with all the things that we're going to do today, it's likely to be 2.5 to 3 hours for us to really get everything done. And then explain to them how things are going to happen. For example, the nurse will be in a little bit to draw your blood and get you your pain medication. Then you'll be transported to X-ray. After they get the films, I will get them back, and then we'll talk again. It's important that you do this at discharge too, that you explain to them how the discharge process is going to work. And an important thing is at the end, thank them for letting you take care of them. Please do not publicly criticize the hospitals. Remember that social media is public, including Facebook, and some physicians have been summarily let go from the hospital because of posts on Facebook. But please feel free to express your concerns in private to me, to any of the emergency department directors, the CMO or CEO of ESP, because we strive to have an open dialogue and feel that the only way to improve is to have honest discussions. In the Baptist Health System, we have a safety reporting mechanism called the MIDAS reporting. This is used for any kind of safety concern that the physician or staff may have. This could be a process that needs to be changed, the lack of equipment, a non-responsiveness of a consulting physician, any kind of safety issue you may have. To do this, you call Access Baptist, which is our transfer center, and give them a brief report on what the issue is. Or you can have the nurse call and give them a brief summary of what the issue is. This takes just a few minutes to do and helps the health system and us to improve our processes and procedures. We always try to fix each other's script problems, so that if you get a call from a pharmacy, please take that phone call, look at the record, and see if you can change the medication. If you do not feel comfortable, of course you do not have to, but we try and, as a patient service, to fix these problems for each other and as a service to one another. Just a reminder, hydrocodone in Texas is now a Schedule II drug and requires special prescription pads to write for it. Quality assurance, peer review issues. Where do these come from? Well, these come out of core measure reviews, deaths in the ED, from the hospital QA committees, referral by hospital staff. It could be part of a clinical initiative such as sepsis or stroke, or any new clinical initiative that we have. Our philosophy on quality assurance is that safety and quality is multifactorial, and best improvements in quality and safety come from changing a system so that you make it easy to do the right thing and hard to do the wrong thing. Of course, there are going to be times when the provider makes a judgment error or has a lack of knowledge, but this is rarely the case. Most of the time, these involve a system that needs to be improved, and that's what we're looking for. So your input is important, but the only way we'll get it is if you actually give us your input. You will receive certified letters at your home address from the hospital quality committees. You may also get an email from ESP, sorry, not EPA, ESP, through the HIPAA compliant Zix mail. But we really need your input to see it as a practitioner at the time, to identify any system issues and to give your opinion about what happened. So let's talk about some of our responsibilities outside the ED. We respond to codes on the floors if we, based on our own judgment, think that we can. We do not respond to MRIs or doctor's offices off-site. Off-site non-clinical areas that are treating Baptist inpatients may bring these patients to the ED for us to resuscitate. For example, if an inpatient is taken to an off-site MRI in codes, they may bring those patients to the ED. Although the policy states that inpatients who are transported off the facility, such as to an off-site MRI, who code, can be brought to the ED, I have never seen this happen. We do not respond to Dr. OBs. We have no obligation to respond for non-emergent or non-coding patients, to put in central lines, to electively intubate a patient, to evaluate a patient that's fallen on the floor. Our primary responsibility is to the ED. Splints. The nurses and techs are not allowed to place splints in the emergency department except for air casts, Velcro removable splints, but all fiberglass splints have to be placed by a physician or an advanced practice nurse or physician's assistant. Consents. In the Baptist Health System, the surgeon or the person performing the procedure has to obtain their own informed consent. The nurses can place the consent form on the chart, but all the discussions have to be done by the providing physician. Pain medication does not make the patient unable to sign an informed consent. There is no Baptist hospital policy stating this. You may still run into some nurses that are confused about this, but if the patient is hurting, you can treat their pain and they can still sign the informed consent. So please do not delay treating the patient's pain for the consent. For medical screening exam, the hospital has a policy which allows advanced practice nurses and physician's assistants to medically screen patients for the absence of an emergency medical condition. The hospital policy does not apply to the physician, but only to the advanced practice providers. Physicians can medically screen patients in compliance with the EMTALA law and their own medical judgment. The Baptist Health System medical screening exam policy is called the Right Care, Right Place policy. Here are the screening criteria which must be absent for the patient to be screened medically by the advanced practice provider. The number 75 T sheet has a general adult medical screening exam template, which the advanced practice providers can start. We can also use for medically screening a patient. After the advanced practice provider has made their assessment about the medical screening, they may decide that the medical screening is complete, and then the patient will be discharged as no emergency medical condition, and they would check the first box here. If they decide further evaluation is needed, they would check the second box, and then they would be seen by the emergency physician. EMTALA is primarily a non-discrimination law, so the advanced practice provider and the physician should make no references to payer status in determining whether an emergency medical condition is present or absent. So here's how the process should work. If the patient is seen by the provider and they determine no emergency medical condition is present, the provider should explain to the patient that we only treat emergency medical conditions and that they will get them some alternative places where they can seek care. The provider then dispositions the patient as medical screening exam in the CPOE, in the computer physician order entry. Then registration will complete their registration of the patient. The nurse then provides the patient alternatives to care, and the patient is discharged. The patients do not receive work excuses or prescriptions if they are medically screened. Here's a list of some of the resources that are given to patients who are medically screened. If the provider determines that the patient does not have an emergency medical condition, they must also complete this form and sign it and date it. Let's turn to trauma. Texas is divided into different geographic regions by the Texas Department of Health Services. We are in Service Area P and are part of South Texas Regional Advisory Council, or STRAC. Our hospitals have 4 level 4 trauma departments and 1 level 3 trauma department at North Central Baptist Hospital. Here are the pre-hospital red-blue criteria used by EMS in our region to determine whether a patient should go to a level 1 trauma center. There are no criteria to determine whether the patient could go to a level 3 versus level 4 currently. These are, once again, these red-blue criteria are pre-hospital, and we may have patients that are beyond the capability of our hospital that do not meet red-blue criteria, or that meet red-blue criteria but can be taken care of at our hospital. For example, if you have a single long bone fracture due to a motor vehicle accident and age greater than 55, you still could probably be taken care of in one of our hospitals. In general, all shock trauma should be med-commed out through Access Baptist. That is, you contact the Access Baptist, our transfer center, and they, through a MedCom, an agreement we have with the level 1 trauma centers, will get a level 1 trauma surgeon on the phone. However, we do have a level 3 trauma center which can take care of a higher level of trauma than our other level 4 hospitals. So what kind of things can our level 3 trauma center North Central take care of? They can take care of small traumatic head bleeds that are stable, patient with skull fractures that are neurologically intact, concussions with a normal CT, spinal fractures that do not have any cord or neurodeficits involved. They will not take any cauda equinas. They will not take any unstable or displaced fractures. If there's a question, you can speak with the neurosurgeon on call via Access Baptist. Things that should not come to North Central Baptist from a neurosurgical perspective will be massive head bleeds with potential for herniation, injuries to the spinal cord, central cord syndromes, even without fracture. Any patient with paraplegia or quadriplegia should not come to North Central Baptist. Here are some of the criteria for patients that can and patients that cannot be treated at North Central Baptist. In orthopedic injuries, open book pelvic fractures, acetabular fractures, calcaneal fractures, tibial plateau fractures, and hand injuries cannot be handled at North Central Baptist. Things that can be handled are solid organ injuries such as stable spleen lacerations, liver lacerations, kidney injuries, hollow viscous injuries, rib fractures with or without pneumo or hemothorax as long as they're hemodynamically stable, multi-system trauma, again, as long as they're hemodynamically stable. Currently in San Antonio, only the Hand Center is doing reimplantations of digits. However, they only do reimplants of thumbs, multiple digits, or digits in a child. These transfers should go through Access Baptist and MedCom. Regional STRAC, or the trauma committee set up by the state government, also has organized the care of sexual assault patients in our region. The state law requires that all EDs have the capability of doing sexual assault exams and treating sexual assault victims. In San Antonio, this has been regionalized to 2 centers of excellence for patients older than 18 years of age. It is at Methodist Specialty and Transplant. For 18 years of age and younger, it is at Christus Santa Rosa Children's Hospital. Sexual assault exams are done if the incident is within the last 96 hours. Here's the general algorithm for how this is done. When we send sexual assault patients to these 2 hospitals, it's important for us to know that they will not see a physician again. They will see a sexual assault nurse who's specially trained in evidence collection. So prior to them being discharged, they should have their sexual assault prophylaxis for sexually transmitted diseases and pregnancy if indicated. They should also be medically stabilized for any injuries they might have prior to discharge. Although the state does not require a transfer agreement, our hospital does. So these patients should have a formal memorandum of transfer done prior to being discharged to go to these hospitals. The accepting care provider will be the sexual assault nurse at the facility. Please also note that for children, the sexual assault exam, that is for 18 of years of age and younger, has to be approved by a law enforcement person. So the family may request a sexual assault exam, but unless the police authorize it, no evidence exam will be done. When the patients, show up at our facilities, we should not tell the patient we do not do sexual assault exams and redirect them to these hospitals. They still need to be registered, receive a medical screening exam, sexual assault antibiotic prophylaxis if needed, and pregnancy prophylaxis if indicated as well. So there should be no AMA transfers. You should leave here against medical advice and go to that facility. All these patients should be seen, evaluated, and a memorandum of transfer completed. To help us in treating these sexual assault victims, We have prepared a order set which has the STD prophylaxis and pregnancy prophylaxis on them. These are not in the computer order entry, but are in the sexual assault packet and can be printed from the Baptist Health System intranet. Occasionally, these patients will decline transfer or refuse transfer to one of the sexual assault nurses for evidence exam. If the patient refuses this, we should first try and explain to them that these hospitals are set up to do this all the time and have a better ability to do the evidence exam. If they still refuse, we should call the house officer who will come and speak to them about this. If they still refuse, they will be asked to sign a form stating that they were refusing transfer to a Center of Excellence for Sexual Assault exam. The house officer then can arrange for a nurse to come in from home who's specially trained to do the sexual assault exams. Now let's talk a little bit about transfers. All transfers in and out of the hospital system need to go through Access Baptist. So if you have a patient who has needs that are beyond the capability where you are practicing, for example, if you have an ear, nose, and throat patient who needs a ear, nose, and throat specialist, but there's none available on the call roster, you should go through Access Baptist to have them assist you in transferring this patient out. The same for all transfers in. All transfers into the hospital should come through Access Baptist. Of note, we do not accept patients in the ED from freestanding emergency departments. All transfers into the Baptist Health System for higher level of care are accepted by the physician who will be the treating physician. For example, if they have a neurosurgical problem, the neurosurgeon should be the accepting physician. If they have a urologic problem, the urologist should be the accepting physician. The emergency physician is not a higher level of care from another emergency department. Furthermore, we do not know whether if the physician needed, the specialist needed, has the capability or capacity to care for the patient. So all transfers need to go through Access Baptist. The emergency physician should not accept patients from other emergency departments because we are not a higher level of care. The emergency physician does not know whether the specialist that is needed is available, has the training to do what is needed for the patient, or whether there's capacity in the hospital for the patient. Once again, these need to be accepted by the specialist who will be treating the patient, not the emergency physician. Here's the algorithm that Access Baptist will use in determining where the patient should be transferred to. Please note that they can help us decide whether the patient can be taken care of at one of our facilities. Specifically, they should be up to date on what the level 3 criteria for trauma are at North Central Baptist, where hand surgery may be available, where ENT may be available. It's important that we use Access Baptist for all transfers in the Baptist Health System. This will allow the system also to track where our needs are in getting patients cared for. Sedation processes and consents and how we document it. This is a very important part of our work in the emergency department is sedation and performance of procedures. 100% of these will be audited, so it's important that we know how to do this correctly, both for the documentation and for patient safety. Sedation has a lot of important steps involved in it. For us, we need to make sure that the consent for sedation and for the procedure are done prior to the procedure itself. These need to be done by the emergency physician. We have specially made consent forms that help us do that. But it is the emergency physician's responsibility to discuss the risks and benefits of both sedation and the procedure prior to the procedure itself. We must complete a pre-sedation assessment. We have a T-sheet provided for that, the 23A. We must include the Malapati score and anesthesia the anesthesia grade of the patient prior to performing the procedure. We must participate with the nurse in completing a timeout procedure. We must have a immediate post-procedure timeout where we discuss the expected course of the patient and any things that the nurse should be looking for. We must do a post-sedation note with all the CMS requirements, which require a full set of vital signs, including temperature. Again, the 23A sedation T-sheet has been modified to allow us to document all these. We must also document a procedure note, which is on the back of the 23A sedation sheet. The nurses will also keep an intra-procedure vital signs and any medications that are given during the procedure. We must sign this also. The patient must also be given both procedure discharge instructions as well as sedation discharge instructions. All procedures in the emergency department that require sedation by policy must also have a consent. Truly emergent procedures such as emergent intubation do not need a consent done prior to them. However, fracture dislocations with sedation, lumbar punctures with sedation, any procedure that requires sedation also needs a consent for the sedation and for the procedure prior to the procedure. As part of the consent, we must also discuss with the patient whether they will or will not receive blood products. I like to tell my patients I've never given blood for shoulder dislocation, but this is something that the government is requiring us to ask them. Non-emergent central lines also require a consent prior to placement. Well, you may ask, well, don't we only put in emergent central lines? We do put in urgent central lines, such as in patients that are being admitted that we can't get access for but are not an extremis. This is an example of a patient that would need a consent prior to placement. Other procedures that don't require consent or only require verbal consent would be things such as abscess IND, laceration repair, splinting, and truly emergent procedures such as emergent intubation or emergent chest tube. So to help with all these steps that we need to complete, we've created a folder that has the necessary forms and checklists for procedural sedation. This should be available in all the EDs. Here's the special emergency department consent for procedure. Notice at the top it has the explanation of what the problem is and what the procedure is, and it also has specific emergency department procedures that we do frequently, such as central line placement, dislocation reduction. As part of the consent, we also have to discuss with the patient sedation. I've heard some physicians saying they call it conscious sedation, but we really don't do conscious sedation. We do deep, moderate, or light sedation, and we should plan for one of these in our pre-sedation assessment. We do not do general anesthesia. However, we generally anticipate having deep sedation. We need to have a consent obtained for non-anesthesia sedation, and this is part of our emergency department sedation and procedure consent form. So again, I would urge you not to use the word conscious sedation. Like I like to tell my patients, we're not going to do conscious sedation. We're going to do brief, profound, deep sedation and get you fixed. One is deep, profound, well-monitored, well-controlled sedation. I don't want to be conscious when my shoulder's put back in place. And the hospital policy on sedation allows us to do this. Another item that may come up is there's been confusion in the past about whether the Nurse Practice Act in Texas will allow nurses to push propofol. It does allow them to push propofol, and our hospital policy does as well, provided that one of the emergency physicians is in the room with them while they're doing it. So if you meet pushback for giving propofol while you're doing the procedures, please let me know and we'll help educate about this again. Here's the portion of the consent that has us ask about blood products. I always tell the patient I've never had to give blood products for any of the procedure I've done, but we have to ask about it. Again, the pre-sedation assessment of the physical exam, Malapati score, anesthesia level, all must be documented before the procedure and timed before the procedure. The nurses are empowered to stop the line if this has not been done. So here's the 23B T-sheet that shows the Malapati score, the physical exam, ASA classification, with the signature and time which must be completed, the left-hand column, prior to the procedure. Please note on the green box on the right is the second column of the sedation T-sheet, which has the post-sedation portion of the reassessment, which is required by CMS with the code written, the CMS code written there. Note that we have to get the patient's vital signs, including temperature and respiratory rate, after the procedure, and we have to document it. We have to document the pain scale and nausea. And again, the T-sheet has been modified to allow us to easily document these things. On the back of the T-sheet, you'll notice that we have added the procedures that we commonly do with sedation so that you can just flip the T-sheet over and document it, the procedure as well as the sedation. Please note, as one of the requirements for procedures to be documented in the hospital system is we have to put a blood loss, estimated blood loss with any procedure. All medications given during the procedure by verbal order have to be authenticated after the procedure and signed by the emergency physician. Here's the nurse sedation flow sheet with the area where we need to sign that. Currently, this is not available in the computer order entry, so we'll have to do this by hand. All patients who have sedation must be discharged home with sedation discharge instructions. They should also have the problem specifics. So for example, if they have a shoulder dislocation with sedation, they should have sedation discharge instructions as well as shoulder dislocation discharge instructions. Just as a reminder, all procedural sedation charts are audited for compliance, and opportunities for improvements, or OFIs, will be communicated to the provider. Jumping gears to electronic death certificate signing, the Texas Medical Board has decided that all physicians in the state of Texas should have the capability to sign electronic death certificates, and they will fine physicians for not having the capability to do this. Signing electronic death certificates does not put us at medical legal risk. This is a disposition and patient customer service problem. If nobody will sign the patient's death certificate of their primary providers, then we should go ahead and agree to do this and note this on the chart. It is not difficult, and it takes a few minutes, and the office can help you set up your electronic provider numbers. The Bexar County Medical Examiner's Office has sent out a memorandum to all the physicians in Bexar County asking them to please be willing to authenticate the death certificates as the Texas Medical Board requires, that this is solely used as providing proof that the patient is dead and helping them dispo the patient. I'm not sure where the fear comes of medical legal that by signing the death certificate, this puts the physician at risk. I'm not aware of any medical legal liability that a physician has encountered from signing a death certificate. Anecdotally, I had a woman visiting in her 90s from Mexico. I didn't see them, but one of my co-workers, co-physicians did, and she died while in the emergency department over overwhelming sepsis. The physician was unwilling to sign the death certificate because he thought that this would in some way implicate him in medical legal liability for the patient. However, the family just wanted to be able to get a death certificate so they could bury her in Mexico. So I signed the death certificate. STEMI activation. All of our facilities have acute interventional capability for ST segment elevation MI, except for Mission Trail Baptist. At Mission Trail Baptist, when a STEMI is identified in a patient, they will be moved to BMC, the Downtown Baptist Medical Center Cath Lab, for STEMI care. The cardiologist on call for STEMIs at Downtown Baptist is the accepting physician. Please note that we can begin the transfer process before we actually speak with that physician. The agreement with the STEMI or the interventional cardiologist at Downtown Baptist is that we begin the transport immediately upon identification with the goal of getting the patients out within 30 minutes of presentation to Mission Trail. We can speak to the cardiologist en route if they are not immediately available. If for some reason they present to the cath lab prior to the physician and the cath team coming, they can be brought to the BMC emergency department until the time that the cardiologist and team arrive. The next two slides have a more detailed examination of how the process works. But the bottom line is when the emergency physician at Mission Trail identifies a STEMI, they call a heart alert, which activates the cath team at Downtown Baptist and the interventional cardiologist at Downtown Baptist. Transfer begins before the cardiologist returns the call if the EMS is available. Split flow. All of our hospitals except for St. Luke's, which is limited by space, have a process called split flow, which means that the patient doesn't own their bed or location. So what this means is that patients can be assigned to either an acute care bed or an intake and procedures bed. After they're seen, they may be moved to results pending, where they await their final disposition. Some patients may be discharged directly from either the acute care bed or the intake and procedures bed. The nursing staff should ask us, or we should tell them, if the patient could go to results pending. For example, if I have somebody that I've seen that has twisted their ankle and they are going to get an x-ray, I could let the nurse know they could go to results pending after they get their x-ray. Or if it looks like it's a fractured dislocation, I should tell the nurse, no, they're going to need reduction and splinting, so don't move them to results pending. Additionally, at some of our facilities, the patient may be seen by an advanced practice provider at triage. where they'll have an initial screening T-sheet started. They may have labs and x-rays ordered at that time. The advanced practice provider may also see the patient and discharge them at that time. In addition, some of our facilities have a quick care where patients are seen, evaluated, and discharged by the advanced practice provider at triage. Rabies. Unfortunately, wild feral animals, cats, dogs, in Bexar County have been known to carry rabies. So what do we do? The initial treatment is done in the emergency departments. The rabies immune globulin, the human diploid cell vaccine are begun by us, cleaning and treatment of the wound. In animal bite form through the STRAC website should be filled out, and then the patient should be followed up for their subsequent vaccinations. If the patient has a physician, they can follow up with their primary physician. If they do not have a physician and are insured, they can follow up with Texas Med Clinics. If they are uninsured, the university hospital system has agreed to follow these patients up for their subsequent dosing. I always tell patients, however, if you can't get back in, you can always come back to the ED. The health department will not fill our prescriptions for the repeat vaccinations. They will only give out the rabies vaccine to the provider who will be giving the vaccination. I know this seems a little crazy, but that's the way it is in Bexar County right now. Restraints. These fall into two general categories, behavioral and medical. Behavioral restraints are used to control a movement of a patient who's violent, who intends to hurt themselves or hurt others after other less invasive steps have been taken to de-escalate the patient. All of these behavioral restraints have to have an order, including the order to hold. Currently in the system, physical hold can only be done for 15 minutes for behavioral restraint and requires a physician order. Chemical restraints. This is something we don't use. This may be partially semantic, but a chemical restraint is a drug used to restrict the freedom of movement of a patient, and it's not a standard treatment for the patient's underlying condition. Chemical restraint is not recognized by the state of Texas and is prohibited. Generally, you can ask yourself, is this done to restrict solely to restrict the freedom of the movement of the patient or not? Or is it done, if it's done just to restrict the freedom of movement or for the convenience of the staff, this is considered a chemical restraint and is prohibited. So what would be an example of a chemical restraint? Say the nurse calls and asks the attending, Grandma keeps getting up and wandering at night. I wonder if we could give her some Ativan to keep her from getting up. Well, this is a non-therapeutic intervention used strictly to restrict the patient's freedom of movement and would be considered a chemical restraint. So here's another question. You have a 32-year-old schizophrenic who is actively hallucinating and combative, and the physician has ordered a dose of Ativan and Geodon, but the patient, after this first dose, continues to be combative. the ED doctor decides to paralyze and intubate the patient so he will not hurt himself or the staff, would this be considered a chemical restraint? Yeah, so this would be considered a chemical restraint. It's not something we should do. It's done primarily to restrict the freedom of movement for the convenience of the staff. So what do we do with these agitated psychotic patients? Well, to help with these patients, we've created an agitated delirium order set. First of all, we don't know that the only thing going on with this patient is psychosis. We do know that being agitated is an unpleasant experience, and we need to treat the patient's agitation. This order set is designed to help us in a stepwise manner manage these patients without using chemical restraint. Here's the agitated delirium order set.